Good evening from Buenos Aires. I'm your host, Nick Kindler, and thank you for joining us this evening for a special SIU at U studio session. Tonight, we are pleased to feature a debate on a controversial subject, MRI ultrasound guided versus transperineal biopsy for prostate cancer. The majority of prostate biopsies are performed by the transrectal ultrasound guided technique, introduced some 25 years ago by Hodge and colleagues. Prostate cancer is the only major cancer in which the diagnosis is now routinely made by blind biopsy of the organ. One drawback with this method is that ultrasound can't readily distinguish cancerous tissue from healthy tissue. More recently, several studies have showed promising results from a more targeted way to biopsy the prostate. This fusion-guided biopsy approach fuses ultrasound images with high-resolution pictures of the prostate made by a newer technology called multiparametric magnetic resonance imaging, MP-MRI. By adding MP-MRI images taken beforehand to the real-time ultrasound images, it permits us to target suspicious regions of the gland while steering clear of healthy tissue. Fusion of MRI with ultrasound allows urologists to progress from blind, systematic biopsies to biopsies which are mapped, targeted, and tracked. So, does this mean we should recommend MRI fusion-guided biopsy for all prostate cancer patients? Is it better than the standard diagnostic tools? To answer these questions and more, our esteemed panel of experts are here to discuss and provide insights on this controversial topic. Our chair for this session is Dr. Badrinath Konety from the United States, and our panelists are Dr. Rafael Salas from France and Dr. Srinivas Vourganti from the United States. Welcome.
Thank you.
Our panel will be happy to answer your questions during the session. For our colleagues connected online, please use the Q&A box on your screen, and if your question is not answered during the session, we will follow up with you after the Congress. Now, to open the debate, I'd like to ask the question to our panelists. Is MRI ultrasound biopsy better at detecting potentially harmful tumors than standard biopsy alone? At this point, I'd like to ask Dr. Konety to open the discussion.
I must confess that I am a little biased, but before I go there, first of all, it gives me great pleasure to be on this panel here and try to answer some very important questions. The question you asked regarding whether the MRI-guided biopsy is better than standard biopsy, to me at this point, having used both techniques extensively, it's like, does the sun rise in the east? Of course it does. I think the MRI-guided technique, in my opinion, is much better than the transrectal standard 12-core biopsy. I'd like to hear what my panelists think as well.
Well, that's exactly as you said. I fully agree. There is a situation today in which we cannot deny the usefulness of MRI-guided with fusion biopsies. We know there are more significant cancers that are identified with the technique. There's less harm because we're going to identify those cancers that we really need to treat, and we might not identify those that we actually do not need treatment. So it is definitely the way to go.
So it's almost sounding like this is not so much a debate as a lively discussion. Do you have another perspective or anything to add?
Yeah, absolutely. I think that as time goes on, there's sort of unanimity in understanding the advantages of MR, and what we'll have to decide is in whom MR is most beneficial. Can we abandon systematic biopsy completely, or should systematic biopsy remain to complement targeted biopsy? These are all very important matters that remain to be answered. So.
I think Srinivas actually made a very good point. It's the question is not whether MRI guided is better than standard. Is it so good that we can eliminate the standard biopsy? Which I'm not sure we have a good answer to that yet. I think that is still something that needs to be resolved. At this point, we can use the MRI as an augment, or the MRI-guided biopsy as an augment on top of the systematic biopsy, because people are still afraid of missing a cancer that is not found on the MRI-guided biopsy.
Okay.
Now, I understand you've got a case study that you wanted to share that might help shape some of this debate, if you will.
Sure, actually, I would. And one of the thoughts I had when looking at this whole question is, since, as you can imagine, there's a fair amount of consensus that MRI-guided biopsy is better than the standard biopsy, but there are still some nuances to the MRI-guided biopsy. It's done with two different approaches. You can either do it transrectally, which is obviously much easier because we're all familiar with the transrectal technique. It can be done in the office, versus the transperineal route, which some people believe is more similar to the saturation biopsy technique that has been used in the past when just using regular non-MRI guided biopsies. So I think there's still some debate whether there's any value in one technique versus the other. I sort of wanted to use a case perhaps to highlight the issue and then maybe get the input of our valuable experts here to see what they think is a better approach, and maybe they can convince us one way or the other. So this is actually one of my real patients. He's a 62-year-old lawyer. In America, we all don't like lawyers, I think, but so unfortunately this is a lawyer. He's got BPH. He was on Avodart for several years. His PSA was fairly low, 4 to 6 range, and suddenly it started rising fairly rapidly. He had a biopsy elsewhere and in the past, but which was negative. And he'd had at least another biopsy within the past year before I saw him, which was also negative. And subsequently, the PSA had gone up to 16.3. And his referring urologist repeated the PSA a month later just to see if this was, just an aberration. And the repeat came back at 11.2. Just remember, he was on Avodart, so really the converted value would be almost double that. He had a PSA of 22, 2 prior negative biopsies. And interestingly, he had an MRI done about a year before I saw him, which was negative. So because the MRI at that time was negative, he'd had a standard biopsy, which was also negative. He has some past medical history, aortic insufficiency and supraventricular tachycardia, but otherwise quite active. ECOG performance status was 0, and he's still practicing lawyer, married, sexually active, and so forth. So the question in this case is, given the situation, first of all, I'd like to get your perspectives on how you use MRI in your particular practice. When do you first use the MRI? And do you always use it before even the first biopsy, after the first biopsy? Or do you base the use of these types of imaging techniques on age, comorbidity, life expectancy, and so forth? So, Rafael, I'd like to hear from you. What do you think?
Definitely when you were presenting the case, right before you talk about the route, transperineal versus transrectal, I think there's still a debate on there. Coming back to the MRI situation, I guess that in our particular practice, we are doing MRI before every biopsy. It's part of our politics in terms of research. So actually, we understand this is not the way it is done in every center. If you go in the community, we know that it's very difficult and very expensive. But in the French situation, the patients are not necessarily paying for these MRIs, so this is a completely different situation. If you ask me if I have to do an MRI before a first biopsy, I would say that probably not. It's not perhaps the best way to go. But obviously, in a case that the one you presented with a negative biopsy and even a negative MRI, the situation is completely different.
What about you, Srinivas? What would you do in your practice?
So I think that there are indications which are much more convincing or clear-cut for an initial MRI. Certainly in the setting of a prior negative biopsy, both the effectiveness of MRI has been established over other techniques and really over other biomarker techniques. And even as such, many cost evaluations that have been performed. We performed a Markov analysis of this, and it's really a no-brainer. And this is one of the reasons why the guidelines, the AUA joint guidelines with the radiology community, state that in the setting of a negative biopsy, then an MRI really should be performed, because not only is it more effective, it's actually cost effective. Now, in other situations, I think there are clearly diagnostic advantages of performing an MRI. And as we go forward and build sort of a foundation of image-guided therapies and things like that, there's reasons. But we will have trouble with the cost. We'll have to justify it. We'll have to change our patterns of treatment. We'll have to be more comfortable leaving certain lesions alone. We'll have to become better. And one thing, when we talk about an MRI for everybody under suspicion, I think that we have to be careful because what we're asking of our radiology colleagues is a lot. And for most places, you'd have to increase your number of MRIs by probably 10 to 20-fold in order to capture all of your initial and I don't know, without the aid of new tools such as computer-aided diagnostics, if that would be possible. But in a research setting and in a situation where we're trying to do a utopian sort of treatment, yes, I do believe that MRI has advantages, but we have to make some decisions who benefits the most in the long run.
So just to be clear, you would prefer to use it after the first negative biopsy, but if given the resources, both of you would use it, resources were not a concern, you would use it right off the bat. Somebody walks in with an elevated PSA, get an MRI. Right. Interesting. And Rafael, you led our ICUD guideline development process for focal therapy for kidney and prostate and diagnosis, kidney and prostate last year. An excellent guideline, by the way, but which is available at this meeting. But looking at the guideline, I think that's one of the things that we actually said in the guideline was that after a negative biopsy, I think we could recommend using the MRI because cost is a constraint. And the radiologists are not all equally adept at reading the MRI, so you can't always, unless you have a great radiology colleague, it sometimes can be challenging to interpret these as well. So on this gentleman, since he's already had 2 negative biopsies, we decided to go ahead and get a MRI again. Though he'd had an MRI that was negative last year, but it is already now 2 negative biopsies, a PSA that's higher. So this is the result of the MRI. We have all the 3 images here. I have the T2 image. I have the contrast image at the bottom there, and the diffusion-weighted image as well. And I wonder if either of you would take a minute to explain to our viewers, which I'm hoping they can get these pictures too. So
absolutely, they're being streamed.
So maybe we can take advantage of these experts. I mean, these people look at MRIs, in their sleep all the time. Maybe they can just give a quick overview of how you read these MRIs and what this means to either of you, and let me help them.
So absolutely. So what we see here, when we talk about multi-parametric MRI, is really 3 ways of gathering MR data. We see an anterior lesion, which is often missed on a systematic sampling, or much more likely missed than, say, posterior lesions. And we see an anatomic image with T2 weighting with decreased signal. With the white arrow pointing this out, you see a DWI, a diffusion-weighted image, and these are ADC maps, which show restricted diffusion. So really the cells are getting packed in, and what you see at the bottom is really a static image, and it really should be played as a movie, but you'll see early uptake and early enhancement and early washout for malignant lesions. And so really this is a classic, probably a PIRADS 5 lesion, especially considering its size. So certainly suspicious.
So can you explain, Rafael, what PIRADS means? I know he mentioned PIRADS, and what is PIRADS, and also what is your threshold of suspicion?
There's been different classifications, but PIRADS comes from a long-standing experience of radiologic evaluation, MRI evaluation, where perhaps the most important parameter is diffusion. That's what I want to look at first sight, is diffusion rather than the anatomical image. So I look at diffusion. If I have something lighting up there, I have to get more detail. Pretty much the size is what makes the difference between the PIRADS 4 and PIRADS 5. And then, as Srinivas pointed out, the uptake and the early uptake is something that you need to really look into detail. Obviously, this image we could say this is like a sitting duck there. The question would be, do I really need to fuse this image in the OR with something to do the biopsy? That would be my first consideration, because this is a huge prostate, perhaps not. That's why they missed it in the transrectal biopsies, conventional. So if you take this patient to the OR with this image, if you do a transperineal biopsy, you could be able, I'm pretty sure that you could be able, by cognitive approach, just to pick up the cancer that's anteriorly located. That is a very good indication for transperineal approach.
That's an excellent point to bring up, because this clearly is an anteriorly located lesion. And you also pointed out that, correctly so, the diffusion image is the most important, perhaps. But I believe there are some nuances, right? If you have a lesion that's in the transition zone, you probably want to rely more on the T2 weighted image. And if it's a peripheral zone lesion, you're better off looking at diffusion weighted. And so there are some of those considerations. Now, there have been some people using B values, the actual level of the diffusion restriction on the ADC map, to quantify it. Are you doing any research on some of those further quantification of these images?
Absolutely. So the diffusion weighted imaging sequence is actually very helpful, and when you raise the B value, right, and use the raw data, essentially you improve specificity. So what's defined as a high B value is sort of a range, and if you have B values in the 1500 to 2000 range, you'll find higher specificity. And what the issue is you'll find areas of suspicion in the prostate, which, much like in many areas of prostate cancer, there are areas of suspicion that are false positives, right? And one of the ways to overcome this, to improve your positive predictive value on a per lesion basis, is to raise this B value.
Very, very well put. So I think this is, just to, again, clarify to our viewers, in terms of PIRADS, clearly this is a PIRADS 5. So what is your threshold for biopsy? Do you biopsy at 3, which is, the PIRADS goes from 1 to 5, and 3 is the indeterminate value. Of course, you increase your specificity the higher the cutoff is. Now, at our center, we biopsy for any PIRADS 3 lesion as well. But some places I know in Europe are only biopsying PIRADS 4 and 5. So I'd like to hear from each of you, what's your threshold, and if prior history and some other parameters matter.
I think you should be biopsying PIRADS 4 and 5. That's a clear indication. PIRADS 3 remains like a gray area. The problem is that you can be asked, okay, if I had this lesion, even if it was classified as a PIRADS, and I had a rising PSA, and this eventually evolved in a not very likely way, why didn't have a biopsy? Why didn't have some tissue out to verify what's going on there? So there's some legal gray area there, but definitely PIRADS 4 and 5 are clear indications.
How about you, Srinivas?
So I actually think that when in the actual delivery of medicine, many of these men are already having to clear a question of suspicion of cancer. And when you have a PIRADS 3 lesion, these areas are targets, and I would be taking them to biopsy, to the biopsy suite anyway, to clear this suspicion, right? So most of my patients are getting a paired systematic biopsy at this time. Now, transition to target only is a consideration. And in that sense, whether you biopsy PIRADS 3 or include only 4s and 5s really is a philosophical one. And it will always be associated with missing some cancers. And so it's paired with the same question: do you biopsy someone at a PSA of 2.5, or do you biopsy someone at a PSA of 4? Really, when you pick these thresholds, we really have to decide as a community what is oncologically appropriate. So if you are talking about someone who's 75 and has comorbidities, to exclude a PIRADS 3 lesion is different than someone who has a long life expectancy. And so you really need to answer this question very subtly. So.
That's actually a very good answer. Because I was sitting here thinking, in kidney cancer, we have Bosniak lesions for complex renal cysts. And we all know that, the Bosniak 3 or 4, we will actually go ahead and take it out, and 1 and 2 we don't do, but 2Fs, sometimes we'll watch. So maybe one approach in the older, sicker patients is to watch and repeat an MRI and see if these 3s evolve into a 4 or 5, and then biopsy them. And if one of them doesn't change as a 3, just leave them alone. So maybe a nuanced approach would help avoid unnecessary biopsies in some of these folks. So in the remaining time, I'd like to actually get both of your thoughts, because I know one of you is more of a champion of the transperineal and the other is more of a champion of the traditional transrectal approach. I think this is USA versus France, but we're going to try to get through the pluses and minuses of each of these. And if you could take a minute, and I'll go through each of these points, and some of them you could probably answer fairly succinctly. Can each of you quickly describe the technique that you use? And Rafael, how about the transperineal? I think many people are familiar with this, but it'd be nice to just give them a quick snapshot. How do you do it?
Concerning the transperineal biopsy, what we do is a procedure is done in the OR on the general anesthesia using a template, a perineal template, just like the one they use for brachytherapy. And it's basically following the principles described by Wiston and Barsel. What we need to have is information. Normally we have information coming from the MRI, and we either you do it cognitively, either you do fusion. Is something to discuss. It's up to discussion. Obviously, this kind of approach is kind of difficult when the patient has comorbidities, because you're taking them to the OR, and it's difficult in terms of cost. It's almost double than when you will do the same procedure in the consultation.
That's terrific. You answered a whole bunch of questions. How about you?
And in contrast to that, one of the advantages of a transrectal ultrasound biopsy is that it's often done on an outpatient basis, awake in the office. But the one thing I really want, in the spirit of international cooperation, I really think that as time goes on, many of these downfalls of transperineal approach are going to be addressed. And the main advantage of a transperineal approach is infectious complications are basically reduced to near zero. And so this 1 to 2% of very clinically relevant infections in transrectal ultrasounds lead to an incredible amount of cost. And I have seen new devices that have allowed transperineal biopsy awake in the office. They exclude at this time fusion, and we're working very diligently with companies to incorporate these devices into fusion platforms. The new fusion platforms, such as the Urinav platform and others, are including a transperineal add-on, which is coming soon, like in the next 3 to 6 months, commercially available. So really what these are going to be complementary things. The only other thing is, and I usually try to be my own gadfly. So as a champion of transrectal ultrasound MR-guided biopsy, I've been in the office and I've had many patients that can't get MRIs, or MRIs are non-diagnostic because of their hip transplant. Their hip implants. They had metal. They have incompatible devices, and so this is about 2 to 3% of men. And if we build all of our platforms on systems that leave these men behind, that's inappropriate. And for these men, I utilize transperineal systematic approaches, which are very helpful, though their downside of retention and cost and general anesthesia. We're working to overcome this, but that really what we want to do is meld the best of both.
You mentioned infection. That's very important, and I think years from now, this is moving pretty fast, and a few years from now, we're going to look back and we're going to ask ourselves how we decided to go through, excrement to take biopsies. This is very simple. Why are you going through the rectum to take biopsies? This is going to question. The people in the future are going to look back and say, these guys were crazy. And I think this is something we need to address.
You bring up a very good point. But, I'm not sure that the perineum is really all that squeaky clean either. It's right next to the excrement. So I'm assuming that there's got to be some contamination. But one of the things I've been intrigued with the transperineal biopsies is particularly for these anterior cancers. I think you have a better shot at really getting an anterior cancer if you go transperineally as opposed to transrectally, because we got to go all the way through the prostate to the anterior fibromuscular stroma. Whereas if you have a small anterior lesion, you can aim for that directly with the transperineal route. Speak to that a little bit. Do you think that's right? Or
it's completely right. There's data from our institution showing that, especially in patients with high prostatic volume, previous negative biopsies, and lesions that are negative, not identified on MRI, transperineal biopsy does the job. That's the job of picking up those cancers that we cannot pick up through a regular rectal biopsy.
I will challenge that, and I do believe that a well-performed, excellent co-registration, and you might even need to change your biopsy probe. So, for instance, if you're used to a side-fire probe, it is difficult to reach the anterior prostate, and these are situations where I would move to an end-fire probe, where the visualization of the prostate and the biopsy trajectory is parallel. And I haven't really found an anterior lesion that we couldn't reach. And this was demonstrated in most of the foundational data sets at the NIH, at UCLA, at NYU. All really anterior cancers are approachable. However, I actually believe the perineum is more of a platform for treatment and really the next generation of moving beyond just diagnostics.
If I may answer that, the institutions you just mentioned are referral institutions, and that's one of the problems.
Yeah.
We always want to bring out their referral institutions information. This is not what's happening out there in the community. So we need to adapt to the community necessities just to become a little bit more real. That's what we perhaps need to, again, address in the future.
Both of you made wonderful points. And, I will say, though, it is more cumbersome to do the transperineal biopsies, and the cost does add. So that is something, even in a smaller hospital setting, that one has to keep in mind. All of these things add costs. Now, how do you think these techniques, I know you were referring to it a little bit, Srinivas, about how some of these techniques are going to evolve over the next 5 years. Expound on that a little bit, and then I'll get Rafael to talk a little bit about what he thinks is going to happen.
Really playing off your comments, I think that every center, as we move to push to future things such as excluding systematic biopsies or moving to MRIs to replace biopsies, they're going to have to assess their own outcomes. I do believe that with software advancements, with technologic advancements, we've all seen the patients that we've helped. We've discovered the cancers in the prior negative situation. We've identified and treated situations, but everybody's going to need to make their own accounting. The other piece of the puzzle is if the audience is mostly urologists, you really have to partner with the radiologists, and you have to help them. You have to perform QA with them. You have to bring them into the fold, make them players in this, so that it's truly multidisciplinary. And if you don't do this, you won't be able to succeed. In the future, in order to move to the next generation, we really have to we need to push. So our center's goal is to develop this in a simulation model, in models, invite people to train, and so that it's not just on the patients. So that's really the goal. And much as ureteroscopy used to be a very exotic art, much as robotic surgery and minimally invasive surgery used to be very exotic, now we have our chief residents going and doing major complex minimally invasive surgery. I believe this will happen with image-guided prostate.
What about you, Rafael? How is it going in France, and how do you think this is going to evolve, not only by diffusion into the community, but also the technique itself?
I believe this is going to be complementary. For many years, we have providing one kind of biopsy that has about 40% upgrade and is not working very well. So we have different kinds of biopsy now. We need to combine transperineal, transrectal, fusion, cognitive. It needs to be addressed by institution, but definitely I think in the future, one of the issues is what I just mentioned. We need to think about a safer way, not necessarily to go through the rectum to pick up prostate cancer.
Now, a couple of questions.
Dr. Konety, we are just almost out of time. I'm wondering if you wanted to say a few words in closing. My apologies.
Absolutely. I just want to ask him two final questions. One is, do you believe that biopsying places patients at risk for cancer development along the track? Just yes or no. Do you think it does that? Do you think it does that?
There have been described cases, and it's rare. Right. It's usually in highly aggressive cancer, neuroendocrine and whatnot. And actually the transperineal approach has actually been described to do this more than the transrectal approach, shockingly. But I used to tell people it was impossible, but there are some reports out there.
Got it. So the final question. You've all, I'm sure, been fully aware of what's been happening in my home country. So who are you going to vote for?
Well, we have the same problem in France.
Good.
Well, I think
I know who they're going to vote for.
that was probably the hottest question on this debate.
Oh, boy.
Not a tie. They couldn't give us an answer.
It's not about voting for the best, but voting for the less worst.
Yeah, democracy.
I would blame the clock and not answer the question. But I will just say thank you for joining us online. Thank you for our audience here. And don't forget, for the folks online, don't forget to complete the evaluation form. It will only take a few minutes, and it will help us develop future content to meet your needs. Follow us on Twitter and on Facebook, #SIU16. And don't forget to send us your picture with for our selfie challenge. I'd like to thank the panel who joined us here today. It wasn't as crazy lively a debate as some of the things we've seen on TV of late, but it certainly was engaging, and thank you very much. Have a great evening, and we'll see you tomorrow.
Thank you. That was fun.